Someone told you to give it time. Maybe it was your primary care doctor, maybe it was a physical therapist, maybe it was a spine surgeon, and you're still sitting here, still in pain, wondering, is it actually going to get better or am I just waiting? I am a spine surgeon and I want to be honest with you about something that most medical content gets completely wrong. The evidence on what actually happens to a lumbar disc herniation over time is generally good news for most patients, but it's more nuanced than it will go away on its own, and it's more nuanced than you need surgery. In this video, I'm going to show you exactly what the research says about the natural history of these herniations and walk you through every non-surgical treatment option, not as a list, but with an honest assessment of what the evidence actually supports for each one. This is video 3 in a 4-part series on lumbar disc herniations. Video 1 and 2 cover the anatomy, classification, symptoms, nerve roots, and the clinical exam. This video assumes you've already have a diagnosis and you're trying to figure out what comes next. First, the natural history of lumbar disc herniations. What imaging studies actually show happens to these herniations over time, why some resolve and others don't, and what that means for your prognosis. Second, non-surgical treatment options, relative rest and activity modification, medications, physical therapy, and epidural steroid injections. For each one, I'm going to tell you what it does, what the evidence shows, and how it fits into the overall treatment picture. And third, how to think about the decision between continuing conservative care and moving towards surgery, because there's a difference between waiting with a plan and just waiting. I'm Dr. Omar Ramos, a spine surgeon at Twin City Spine Center in Minneapolis. I evaluate patients at every stage of this journey, from the first week after diagnosis to patients who've been managing symptoms for years. And I've had this exact conversation, the what do I do now conversation, hundreds of times. What I'm going to give you today is what I give those patients, an honest read of the evidence with no agenda towards any particular treatment. Let's start with what the research actually shows, the natural history and what actually happens to a herniation over time. Let me start with the finding that generally surprises most patients and honestly surprises a lot of non-spine physicians. Multiple high-quality imaging studies, MRI follow-up studies tracking patients over months and years, have shown that lumbar disc herniations can and do decrease in size over time, often significantly, without any surgical intervention. The numbers are meaningful. Studies tracking patients with lumbar disc herniations over 12 months show that a substantial portion, in some studies the majority, demonstrate partial or complete resorption of the herniated material on follow-up MRI. And here's the part that matters most. The larger, more dramatic herniations, sequestrations, and larger extrusions actually show the highest rate of spontaneous resorption. That is counterintuitive. A bigger herniation isn't necessarily a worse prognosis. The mechanism behind spontaneous resorption is immunological, and it's one of the most clinically important concepts in understanding this herniation natural history. When disc material, particularly nucleus pulposus, is extruded or sequestered into the epidural space, it's exposed to the body immune system in a way it normally isn't. The nucleus pulposus is what we call an immune-privileged tissue inside an intact disc. The immune system doesn't typically encounter it directly because it's inside of the disc. Once it's outside of the disc, the body recognizes it as a foreign material and mounts an immune response. Inflammatory cells, macrophages in particular, infiltrate the herniated tissue and begin breaking it down. Over weeks to months, this process can resorb the fragment significantly and make it much smaller, sometimes completely absorb it. This is also why non-contained herniations, the extrusions and sequestrations we covered in video 1, show higher resorption rates than contained protrusions. A contained herniation has not exposed the nucleus to the epidural space in that same way, and the resorption mechanism is less active because of that. Now, how long does this process take? Most of the observable resorption in MRI occurs within the first 6 to 12 months after the herniation. Significant resorption reduction of more than 50% in herniation volume has been documented within that window in a meaningful portion of patients. Symptom improvement often precedes imaging improvement. Patients frequently report significant relief in their radicular symptoms, the leg pain, the numbness, before the MRI shows a corresponding change. This is partly because the inflammatory component of the nerve root irritation can resolve faster than the disc material physically resorbs. The 6-week window before imaging that I mentioned in video 2 and the general recommendation for a trial of conservative care is grounded in this biology. The disc is not static, it's actively changing. But, and this is the part that gets left out, not every herniation resorbs. Not every patient improves with conservative care, and the timeline for acceptable symptom management is very individual. That's the tension we're going to address in the treatment section. Here's what I want you to take into the treatment section. The natural history data tells us that time and biology are working in your favor in most cases, but most cases isn't a treatment plan, and give it time without a structured framework isn't the same as conservative care. What I'm going to walk you through now is each treatment option, what it actually does mechanically, what the evidence shows, and how it fits into a coherent plan. Let's start with non-surgical treatment options. Activity modification and relative rest. The first and most foundational principle of early herniation management is activity modification. And I want to be precise about what that means because it's frequently misunderstood in both directions. Bed rest is not the recommendation. The historical advice to rest in bed for days or weeks following a disc herniation has been studied and found to be inferior to staying active. Prolonged bed rest leads to deconditioning, increases the risk of depression and anxiety, and does not accelerate recovery. On the other side, returning immediately to heavy loading, prolonged sitting, or the specific movements that provoke your symptoms is also not the recommendation. The evidence-supported approach is relative rest and activity modification, maintaining movement and basic function while temporarily reducing the activities that mechanically load the affected disc or provoke radicular symptoms. In practical terms, walking is encouraged. Prolonged sitting should be modified. Heavy lifting in flexion and rotation should be temporarily reduced, and the specific provocative positions are something to work through with a physical therapist. Let's go through medications now. There are several medication classes used in the management of lumbar disc herniation with radiculopathy. NSAIDs, ibuprofen, naproxen, and their prescription strength counterparts are the most commonly used first-line medications. They address both the pain and the inflammatory component of nerve root irritation. The evidence for short-term benefit is reasonable. Beyond a certain dose, more medication doesn't produce more benefit, and longer-term use carries gastrointestinal and cardiovascular risk. Oral corticosteroids. A short course of oral steroids, typically a methylprednisolone dose pack or a short prednisone taper, can provide meaningful short-term reduction in the inflammatory component of the radiculopathy. The evidence shows short-term benefit. It does not alter the long-term natural history of a disc herniation. Muscle relaxants are commonly prescribed and may help with the secondary muscle spasms component of the back pain. The evidence for their benefits, specifically in radiculopathy, is more limited, and sedation is a significant side effect. Gabapentinoids, like gabapentin and pregabalin, are sometimes used for the neuropathic pain component of radiculopathy. The evidence in lumbar radiculopathy specifically is mixed. Both carry meaningful side effects profiles, including sedation, dizziness, and dependence risk with longer-term use. These are not first-line agents. Opioids. I'll address this directly. The evidence for opioid use in lumbar disc herniation with radiculopathy does not support their routine use. They do not address the underlying mechanism of inflammation. The risks are significant, and there is no evidence that opioid use alters the natural history or improves the long-term outcomes. If you have been offered opioids for disc herniation pain, that warrants a direct conversation with your prescribing physician about any alternatives. Physical therapy. Physical therapy is the cornerstone of non-surgical management for lumbar disc herniation with radiculopathy. And I want to be specific about why. Because go-to-PT is advice that often gets delivered without any explanation. The goals of physical therapy for lumbar disc herniation are not primarily about stretching or massage. They're about three things. 1, directional preference and centralization. Many patients with lumbar radiculopathy have a directional preference, a movement direction that reduces their leg symptoms and moves them toward back centralized pain, which is a positive prognostic sign. A trained physical therapist, particularly one familiar with McKenzie methodology, can identify this directional preference and build a home exercise program around it. This is one of the most mechanically targeted interventions we have for this herniation. 2. Neural mobilization. Specific techniques designed to improve the mobility of the nerve root itself, reducing its adherence to surrounding structures and improving its tolerance to movement. These are not the same as generic stretching. 3. Core stabilization and motor control. Building the muscular support system around the lumbar spine to reduce compressive and shear forces at the disc level. This doesn't fix the herniation, but it changes the mechanical environment the disc is operating in. What the evidence shows, multiple randomized controlled trials and systematic reviews support physical therapy for lumbar disc herniation with radiculopathy. The SPORT trial, one of the largest surgical versus non-surgical trials in spine, showed that a meaningful proportion of patients managed non-surgically with structured physical therapy had outcomes comparable to surgically managed patients at 2 and 4 years follow-up. What good PT looks like for disc herniation. A therapist with experience in lumbar spine pathology, a directional preference assessment in the first session, and a home exercise program you can maintain between sessions. Generic back exercises or passive modalities like ultrasound and heat alone are not what the evidence supports as the active ingredient. Epidural steroid injections. Epidural steroid injections, or ESIs, are one of the most commonly performed procedures in spine care and one of the most frequently misunderstood by patients. Let me explain exactly what they do, what they don't do, and what the evidence shows. The mechanism. An ESI delivers corticosteroid medication, a potent anti-inflammatory, directly into the epidural space, in proximity to the inflamed nerve root. The goal is to reduce that local inflammatory response around the nerve root, the chemical irritation component of the radiculopathy. This is distinct from surgery. An ESI does not remove the disc material. It does not decompress the nerve mechanically. It addresses the inflammatory component of it. There are 3 main injection approaches. The transforaminal approach, also called a selective nerve root block, which targets a specific nerve root level and site, delivering medication in close proximity to the affected root. The interlaminar approach enters the epidural space between the lamina and provides broader epidural spread. The caudal approach enters through the sacral hiatus and is used in specific situations. Your provider will select the appropriate approach based on your individual anatomy and imaging. What the evidence shows for ESIs, and I want to be precise here because the evidence for ESIs is frequently oversimplified in both directions. ESIs have good evidence for short-term benefit, reduction in radicular pain, improved function, and in some studies, reduced rates of surgery in the short term. Multiple randomized controlled trials support this. What ESIs have not consistently shown is significant effect on long-term outcomes at 1 to 2 years. The natural history catches up. Patients who received ESIs and patients who didn't tend to converge over time. The clinical role for ESIs is that ESIs can meaningfully reduce the severity and duration of acute inflammatory phase of a herniation, allow patients to participate more effectively in the physical therapy, and in some cases, bridge patients through that natural window without requiring surgery. They are not a cure. They do not alter the underlying disc pathology. The general framework I use in patients with significant radiculopathy who are not responding adequately to medications and physical therapy and who do not have an indication for urgent surgery, an ESI is a reasonable next step with the understanding of what it can and cannot accomplish. What about chiropractic and other approaches? I get asked about chiropractic care, acupuncture, and massage regularly, so let me address them directly. For chiropractic and spinal manipulation, the evidence in acute and subacute low back pain shows modest short-term benefit for some patients. The evidence base specifically in lumbar disc herniation with radiculopathy is more limited and mixed. There is a specific concern worth raising. High-velocity manipulation in the setting of an acute significant disc herniation with neurological involvement carries a theoretical risk of worsening the herniation or the neurologic deficit. This is not universal contraindication, but it's a conversation worth having with whoever is providing that care. Acupuncture has some evidence for benefit in low back pain generally. Massage therapy may help with the secondary muscular component and is generally low risk. My clinical position on it, I don't dismiss modalities that patients find helpful and that carry low risk. What I do encourage is honest evaluation of what each modality is targeting and what the evidence supports for your specific presentation. But again, if it's a low risk treatment, it's worth trying. Here's the question I want to answer before we close out this video. You know that herniations can resorb. You know what conservative care options exist and what the evidence shows. But the question I hear most often, the one that actually matters, is this. How do I know if I'm a candidate for conservative care or if I already waited long enough? So I'll guide you through how to think about this decision. There is no universal timeline that determines when conservative care has failed. The decision to move from conservative management towards surgical evaluation is individualized, but there are clear factors that guide it. What makes conservative care the appropriate path? You have a contained or moderately sized herniation, your neurologic exam is intact or shows only mild findings, your symptoms, while painful, are tolerable and not progressively worsening, and you're within the first several weeks or couple months of onset. This is the profile where the natural history data is most favorable and where structured conservative care has the strongest evidence. What makes the conversation about surgery more appropriate? Progressive neurologic deficit, motor weakness that is worsening, or a new neurological finding developing changes the urgency. A patient who has stable radicular pain is different from a patient whose foot drop is getting worse week over week. The duration of symptoms also matters. Patients who have had significant radiculopathy for more than 6 to 12 weeks, despite adequate conservative care, and who have a herniation on imaging that corresponds to their symptoms, are appropriate candidates for a surgical consultation. This is not a failure. This is the process working as it should. Quality of life and function. This is real and it matters. There is no evidence-based method for tolerating pain longer than necessary. If your symptoms are preventing you from working, sleeping, or participating in life in a meaningful way, and conservative measures have been tried appropriately, this is a legitimate factor in the decision. The cauda red flags from video 2, bladder dysfunction, bowel dysfunction, saddle anesthesia, and progressive lower extremity weakness, these are not conservative care situations. These are surgical emergencies. If you have those symptoms, this framework doesn't apply. You go to the emergency room right now. The honest summary: conservative care is not about waiting and just waiting. It's about giving the biology time to work, supported by appropriate treatment, while monitoring for the factors that would indicate that surgery needs to enter the conversation. And surgery, when it's indicated, is not a failure of conservative care. It's the next tool in a well-designed treatment pathway. Let me bring this together. The natural history of a lumbar disc herniation is generally favorable for most patients. The biology is working in your direction. Resorption happens. Inflammation resolves. The majority of patients with lumbar disc herniations managed appropriately with conservative care improved significantly without need for surgery. But most patients, it's not all patients, and conservative care means something specific: activity modification, medications used appropriately, structured physical therapy, and injections when indicated, not just passive waiting. The factors that shift the equation are real, and knowing them gives you a framework to evaluate your own situation and have a more informed conversation with your care team. In video 4, I'm covering the surgical side of this equation, exactly how spine surgeons decide when surgery is the right call, what a lumbar discectomy involves, what recovery looks like, and what the outcome data actually shows. If you have been wondering whether surgery is in your future, that's the video that will give you the clearest picture. If this series has helped you understand your diagnosis and your options better, share it with someone who's going through the same thing, and subscribe so you don't miss the final video. I am Dr. Omar Ramos, a spine surgeon at Twin City Spine Center in Minneapolis. I'll see you on the next one.